So we have John Law, who's Global Director of Benefits, Total Rewards America for Pitney Bowes, who will be presenting first. We have Noelle Mack, who's Principal Consultant for National Benefits at the Williamson Group. And finally, Joan Weir, who's Director of Health and Disability Policy for Canadian Life and Health Insurance Association. So welcome, and we look forward to hearing your presentations. So we'll begin with John Law.
Wow, okay. No pressure after those introductions, none whatsoever. And then to make matters worse, they go and put us up in front of this glass-type podium. So, yeah, you guys get to watch my legs do this while I stare out at all of your faces. Thank you very much. I'm feeling very judged right now. All right, well, in any case, I want to thank you for the opportunity to be on this panel and speaking at this forum as an employer representative, a plan sponsor, if you will, all right? I work for a private enterprise-sized employer. Now, that can be interpreted to mean an organization with a workforce in excess of 500 people. That's the way we essentially look at an enterprise-sized organization here in North America. Now, according to current Statistics Canada information, only about 45% of working Canadians are actually employed by organizations of this size, which would very obviously mean, from logic, that the majority of employees do not. Okay? Now, 45% of the workforce would still be considered a very representative sample, but I raise this point for a couple of very important reasons. First, it speaks to available resources, as we assume that the larger the company, the more resources are going to be available to perform various functions or to fund various programs. And the converse would supposedly also be true. It's an assumption that a surprising number of people do make. So I wanted to put it out there so that we're all aware that that perspective does exist. Bigger means more resources, smaller means less resources. It's an assumption, a bias. Second, it should also be clarified that some of the largest employers within the enterprise size group is actually government. This is a very important distinction. While governments may share many of the same concerns and issues, they are not private enterprise. And the public approach to dealing with similar problems may be very, very different. So, I put all of that out there essentially as a preamble to ensure that that way nobody misunderstands the perspective that I'm coming from. I am not from the public enterprise. I am not taking from the public purse, so to speak. All right? So my perspective is definitely going to be one of, well, for lack of a better term, profit motivation. This is a very important distinction. Okay? So let's see if we can move this thing right. All right, so sponsored group benefit programs have been around for a very long time. They're intended to be used in the size of a collective group of individuals and the relative frequency or infrequency of specific claims inside of the group in order to effectively work. Now, I'll leave it to others on the panel to provide more expert information on the mechanisms of insurance and instead focus on the employer perspective. I'm going to talk about why we provide enhanced medical coverage, and what are the ideal outcomes. What are employers experiencing? How do we as employers view the rising cost of group benefits? What steps are employers considering or actually taking now to contain and control the cost of benefits? And what about flexible programs and the impacts of well-being and wellness initiatives? There's a lot of talk inside of the media about flex benefit programs and the like, and I'm going to touch a little bit on some of those. And then the final thing that I want to actually talk about is what is our core business focus as a company? Now, initially, such coverage was a differentiator, a way to stand out from the competitors in order to recruit the most desirable talent for the workplace and to keep the current workforce in place. Spending time and money in seeking out or training new employees are both monetary and productivity costs. Similarly, when employees are off sick or injured, proper use and use of these and other programs can help to improve recovery times and reduce and direct indirect disability costs which come from reduced productivity or the hiring of temporary replacements. Within the rewards environment of many employers now, these programs are assumed to be a component of the total compensation package. This is an exchange that exists between employers and employees. This changes such programs from being differentiators to essentially table stakes now. They need to be included almost automatically as part of a compensation package offering in order just to attract and keep our employee talent. Now, most programs have a fairly consistent and similar suite of benefits with standard deductibles and co-insurance levels. Again, I'll leave that to subject matter experts to provide you with more detail on that. Larger employers may also be able to do things like influence drug formularies, co-insurance levels, and reasonable and customary maximums after, of course, they deep dive on their own historic utilization experience. Now, these types of changes would usually be applied after much analysis, and generally they would be applied across the board so that no single subgroup within the program would be advantaged or disadvantaged over another. Now, some employers try to differentiate themselves by being creative and placing non-traditional items on the table, things like subsidized lunches, ping pong tables, pet insurance, and even access to vacation properties as benefit incentives. Now, given the focus of this group and panel, I won't spend time on those particular outliers, but we can certainly chat during the break. So, what are employers experiencing now? Ideally, we're looking for our employees to have a sense of satisfaction, secure in the knowledge that there are programs in place to assist in both proactive and responsive ways. Unfortunately, the reality doesn't align with that. And anecdotally, we have experienced employee dissatisfaction expressed within surveys, town halls, and around the virtual water cooler. When we deep dive on issues, we find that in many instances, this dissatisfaction stems from a lack of knowledge. Many people have a less than cursory understanding about their benefit programs, and this lack of awareness leads many to believe that they have insufficient coverage or no coverage at all. The gap can be addressed in part through enhancing communications through benefits, but in general, people do not pay attention to their programs until they encounter a situation where they have an immediate need and urgency. That's a reality. If I don't need it, I'm not going to think about it. I'm fairly confident that that holds true for every person in this room. If you don't need something, you're not thinking about it. You don't care about it until it's become something urgent. Then suddenly your focus is almost all-encompassing. Now, this becomes more problematic when answers are not quickly available. Often people will ask colleagues or managers who may or may not be the best and most up-to-date sources for the appropriate type of information. In addition to this dissatisfaction, employers must also contend with the challenge of rising costs to provide these plans. Whether an employer has a fully insured program, a refund accounting management arrangement, or just pays for administration and adjudication services, the annual costs for these programs continue to climb. And for many employers, this occurs at a pace that exceeds improvements in our revenues and profits. Now, this paints a fairly dim picture, given that the insurance industry and the advisors, brokers, and consultants that help employers to negotiate through it are all sharing a bleak outlook of potentially even more rapid cost increases with the escalating use of expensive specialty drugs. Disability expenses rise with decreases in presenteeism being replaced with increases in approved absenteeism. The challenge of securing temporary replacements or the impact of spreading the work onto the shoulders of co-workers affects productivity and comes at a higher cost. Even return to work efforts can be challenging given the inability to do anything meaningful with significant restrictions that have little chance of being realistically workable. In my own experience and that of many of my colleagues in many companies across many industries, some doctors' notes and return to work reports have recommendations that have employees doing very little or set a work rest schedule that is completely disruptive and is of no practical value. This subsequently impacts on more than one worker's productivity. but also on the morale and productivity of those who continue to work around them. Some employers with more means create specialty departments with clinically trained staff to assist in designing and following up on return to work, or they hire out to vendors who have that specific expertise and can assist them in bringing people back to work. One thing that you have to think about, though, is that all of this means increased costs for employers while seeing a decrease in effectiveness and productivity. It's a vicious catch-22. So, what do we as employers do to address the cost issues? We initially tried to contain the problem by using less expensive alternatives. Things like the use of generics, reducing the frequency of fills on chronic care medication would certainly be some of the ideas that would be out there. Then what we do is we have to impose limits if that's necessary. We may put formulary restrictions on things or introduce things like step therapy. Only if things get really, really bad do we then take the final step of actually having to cut costs or even eliminate. The challenge we face is that we're viewing our problems across our entire workforce. And so the steps we take to protect the overall program is intended to be equally applied to all. Unless we're willing to significantly increase the administrative burden on ourselves and our insurance providers, we don't want to cherry pick and take steps to single out a smaller subgroup or individual. That would be discriminatory, unfair, and counterproductive. Directing plan design changes around small subsets brings its own challenges, and what individuals often fail to realize is that it actually makes things more expensive as you limit or even lose the collective protection and advantages that can be associated with larger groups under a group benefit program. Now, flexible benefit programs are an interesting phenomenon, and they have certainly gained traction in terms of their popularity and the way they are marketed as an option. There are many different ways that flex can be approached, and there are many who are more expert than I who can certainly speak more on the topic. But I want to address the idea from an employer's perspective, and this is not necessarily a point of view that is shared as broadly when it's marketed to companies. Fundamental to these programs is the premise that people are provided with a number of options and levels of benefits and coverage that they can select from. Each plan member will make choices that best align to their needs, and they have the option to choose and update these on a regular basis, usually annually, or if some other type of identified life event occurs. That sounds wonderful. I get exactly what I need when I need it. Sounds perfect. Up until a few years ago, my own organization had a flex plan design that had been in place for almost 2 decades. There were some smaller adjustments that we had made over time, but it was a veritable buffet with more than 260 different ways that a program could be mixed and matched to create what should have been a nearly perfect customized benefits plan for each and every employee and their eligible dependents. 260 different ways. Surveys and other forms of feedback indicated very low levels of interest. And satisfaction with the benefits program was at an all-time low. Enrollment data suggested that nearly half of the workforce would not be making selections that exceeded the lowest level of potential coverage. They have choice, but fail to choose. With the potential costs associated with things like the increased use of biologics and other specialty medications, the direct impact to them financially was the bottom of the iceberg that was being ignored but kept coming closer and closer. And those that did choose would choose what they believed was going to be important to them in the immediate future. They would effectively select benefits and coverage levels that they expected to utilize. Everyone would act or not act according to their individual needs, but as an employer, we have to look at those individual choices and how they collectively impact upon our plan as a group. Now, adverse selection is an interesting concept in both economics and risk management. It's a situation where one party has different information from the other party. If the insurer offers a benefit and initially prices it for a large group so that each member pays a smaller amount, but then only a small number of that group actually take advantage of the benefit, and those that do take it actively go and use it, the benefit offering as originally made is not sustainable. The only ones that can that are taking the offers are the ones who are definitely making use of it. So the risk is not spread out across the larger group, the larger numbers. In order to continue to offer the benefit, the price has to go up, or the offering must be reduced or withdrawn. Now, this is the slippery slope that employers have to contend with in some flex models, as it means either accepting higher costs or using other methods to allay some of these increases. Whether it's a flex plan design or not, if cost sharing is involved, then employees are feeling that they're paying more but not receiving any improvements in their programs. Effectively, they see the value as being diminished since they're seeing an increased contribution and they're only getting the same thing or even possibly less. Their perception of the program is lowered, which is the opposite of what employers are trying to accomplish in the original provision of benefits when we're trying to use it as a differentiator and attract people. We don't want them to have low opinions of their programs. On top of this, we have demographic changes that are also being felt. As the last of the boomers, there are a couple of us here in the room right now, prepared to retire over the next decade, and Gen X and millennials are exercising increasing influence with their own expectations of what they believe they need. Employers are looking at shifting from the traditional benefits paradigm with its protection focus to more of a proactive prevention focus. This means finding ways to try and engage employees to embrace healthier lifestyle choices. Insurance industry statistics suggest that a significant percentage of prescriptions are issued for conditions such as high cholesterol, high blood pressure, and diabetes. These are all conditions that in many cases can be significantly and positively impacted by healthier lifestyles with changes in diet and exercise. Wellness and well-being programs try to encourage these changes, and other incentives are sometimes introduced in order to build enthusiasm for activity and change. The desired outcome from this will be a lasting change that reduces the incidence of preventable disease conditions, as well as the associated costs of treating them, especially in the more severe and consequently more expensive situations for both the pharmaceutical as well as potential disability costs. This shift in focus may mean higher costs in some areas of benefits, but the expectation is that this will be more than offset by the reduction in the possible need to utilize as many chronic medications, or even worse, the more expensive specialty drugs as the conditions worsen. Maintaining a higher level of health and well-being also means avoiding loss of productivity and the potential incurred direct and indirect costs associated with managing disability claims. Now, these are obviously some of the things that weigh heavily in the minds of many employers. And you can add to this the very real desire to want to try and help our people in times of illness, to try and assist where possible by using the best tools to support them and return them to health. But keep in mind that all of these things take away from our focus on our actual business. In the private sector, this will be the driving force that creates the profitability to fund the benefit and welfare programs that I've been talking about. And these are not our core focus. And too often employers feel like they're being viewed by clinicians and their patients and advocates, our employees, as an evil player in a zero-sum game where we win and everybody else has to lose. We all have a role in helping to sustain our benefit programs, and we all have a stake in being able to successfully do so. For myself and my family, I know that there are times when, at the doctor's office, the first question that is asked before writing a prescription or having one filled subsequently at the pharmacy is, do you have a drug plan? How many people have heard that from either their doctor or their pharmacist? Show of hands, please. The overwhelming majority of you have just raised your hands. Now this is interesting. I want you to remember what you just answered there. All right? I have feedback from many others across the country that suggests that my experiences are nowhere unique. And you've just demonstrated that again here in this room. What changes for those who do have a plan and for those that do not? Do you have a different prescription? Do you write or fill with an available generic? Do you more closely follow progressive step therapy instead of prescribing the newest cutting-edge medication? What's actually changing? What we need to do is we need to redesign the question. And we have to try and figure out collectively, what does success look like for all of us as stakeholders. Success would be finding a way to sustain these programs by balancing cost and efficacy. It's something that's already being done, as evidenced by what the "do you have a drug plan" question being asked means. We already know it's being done. In their heads, there's already a balancing act being done. And we have to challenge the vendors and the doctors to think about that as they're going through the process. Providing more meaningful and useful information to help return people to work, whether it be modified or full return to work duties. A demands analysis based on objective medical information is completely within a clinician's jurisdiction. However, defining work duties and scheduling work is not. And all too often, that's the kind of stuff that they're providing back to employers. That's not what we need. We need to know what is it that a person can or cannot do. Don't try and schedule or determine what their work is. You don't know what it is. That's our job, not yours. Stick to what you know. It's not a my patient versus my employee scenario where one perspective has to supersede the other. Understand that we both want the same thing, a healthy and productive individual. We all have a role, and we should be partnering more effectively. Reducing these costs allow employers with more resources. It provides us with more resources and an opportunity to consider new plan components and levels by reducing the costs. It's challenging for people to think of benefits as a collective when they're making decisions as individuals. The what's best for me perspective creates an environment for the rapidly escalating costs that makes sustainability untenable. Do you plan to have a car accident and go out and purchase insurance just prior? Do you plan to get sick or injured? Who does? But this is effectively the decision process approach that many people use in their group insurance choices. They don't put the coverage in place until they actually need it. Or if something comes up and they actually need it and they haven't made the choice, then they're expressing dissatisfaction because they made the wrong choice. You have to encourage people to seek information from the proper sources. For benefit programs at work, talking to the human resources advisor is usually better than chatting about experiences around the water cooler. In 30 years, I haven't been in any discussion where we're talking about benefits, whether to an individual or to a collective group, where I didn't hear, I didn't know we had that. All right? The plans can help if they're used effectively, but we all have to be able to understand that it's not a blank check. We need every stakeholder, employee/patient, clinicians, advocacy groups, and the company itself to all do their part so we can continue to afford to actually provide these plans. Thank you.
This is a very interesting crowd because I don't recognize a lot of faces, but a few of them. So if you've heard my jokes, I'm not a stand-up comic. Just put your hands over your ears and hopefully the new audience chuckles politely. So my name is Noelle Mack. I work for an independent consulting firm. We're considered a boutique. We're across the country, but predominantly from Windsor through to Ottawa. We have national employers and international employers as clients as well. And almost all of our work is on the employer side, very little union work. So this slide really is just to tell you that I'm old. 32 years in the business next month. We work with employers across all sizes and all industries. Our sweet spot is the 500 to 750 employer size, though we do have large international corporate entities as clients. And again, all types of industries, for-profit, not-for-profit, and I've also done some municipality, university, school boards, and hospitals, the mush crowd in my career. So what I want to go through now is kind of building on what John said, and we didn't prep together. Well, I've known John for a long time. We didn't do our homework together. But John's already touched on some of the things, and I'll expand on it. So what's gone on over the number of years as far as plan design and trying to control costs is not very creative. It's just shifting the cost to somebody else. to another person, either to another plan, if someone has coordination of benefits through a partner or spouse's plan, or out of their own pocket. But what we're also seeing is someone else now is being asked to pay as well, based on plan design. So some of the things that we've seen is that let me back up, most of this really started taking place in 2009, 2010, when the economy started to tank. You know, they had to make some drastic changes to plan design to keep them sustainable because they needed the cash flow. So a lot of plans went from a copay where there was none before to adding one in to 90 to 80%. And I'll reference the Toronto Board of Trade's 2016-2017 Employee Benefit Benchmarking Survey. So for salaried employees, only 39% of the plans pay 100% of the premium, or 100% of the cost. 13 had a 10% copay, and 41% had a 20%, and then 6% for their other. So most plans today have some type of copay on their drug spend or another part of the extended healthcare plan. And I'm going to focus on the extended healthcare plan for this. Some added or increased deductibles, and the issue with deductibles is that it's a flat dollar amount. It never stays constant with inflation as it goes through. So a lot of plans, if they had them, they moved off of it and they moved to a copay. They added or increased professional fee caps. So this is on the pharmacy side in particular, where it used to be reasonable and customary. Reasonable and customary in Ontario, anyone here from the insurance industry will not like me saying this, but you know, it's really $12. They don't like to communicate it because if there's any pharmacists in the room, don't jack up your dispensing fee so you can hit the reasonable and customary. But what happened was a lot of employers put in a maximum on the dispensing fee to something less than reasonable and customary. And one of the objectives there is to A, shift some cost to someone else, but also to make their employees and their dependents more conscientious consumers of the plan. You can get a dispensing fee anywhere from $4.65 to $12, and even in some places we've seen some what I'm going to call rogue pharmacies put in $15, $16 dispensing fees. Right? So as a consumer, you have the opportunity to go to whatever pharmacist you want, but we wouldn't recommend you pick your pharmacist just simply because of the dispensing fee. Again, not being disparaging to pharmacists, but it should be for something more than knowing what to count and how to count. It should be for giving counsel on what you're about to take. So once you find a pharmacist that you're comfortable with, regardless of the dispensing fee, if you're getting value for that dispensing fee, that's the pharmacist that we think you should stay at, because you could get a drug prescribed that if you pharmacy shop, the pharmacist you go to may not know what your other medications are. They may not know there's a contraindication of the drug you're about to take with the drugs that you should be taking. So if you stay with the one pharmacy, that information is going to be there. That's the true value, I think, out of the dispensing fee and the cognitive fees or the cognitive services that come out of pharmacy. The other thing to keep in mind, too, is that the majority of plans today do not have a premium sharing. So if it's an insured plan, there's going to be single, maybe single, couple, family rates. They pay almost the whole freight. So keep that in mind when who's paying, who gets to decide on the plan design. It's a key thing that happens there. If I'm paying the whole shot, house money, house rules. Some of the other, and again, I'm being disparaging to my own industry because we haven't come up with a lot of creative things either. And this is the one I don't necessarily like, but we're seeing this as a growing trend where people are putting in an annual drug maximum that, and sometimes are ridiculously low as $5,000 per claimant per year. We may see some go up higher. I think the highest annual drug maximum on the plan that I've ever reviewed is $50,000. We've seen lifetime maximums in place as well, where it was $1 million. I have a number of plans, number of clients that every year now that I have to run a report to look at how many people are going to tip $1 million in lifetime spend with this employer. You know, and it's getting more and more, the list is getting bigger and bigger. But the plan design is the plan design. When they hit that maximum, we can't do anything about it. That is the plan design, the contractual limitations of it. Now someone else is going to pay. So why are they doing it? Well, in some cases, the small employer, and John touched on this to some extent, but the fact is that 95% of employers in Canada employ less than 100 employees. So 95% of employers have less than 100 employees. So the employee benefit cost is a big ticket item. We have seen where a small plan, let's call it 25 lives or 25 employees, in a normal year at renewal time, we would be expecting a 15% increase in their extended healthcare costs. That's just normal. Healthcare inflation is now getting closer to 13, 15%. So if they performed as expected last year, next year costs are going to go up 15%. But if that plan gets hit with one specialty drug in my world is anything over $10,000 a year, that 15% increase could become 52% or more, just because of one drug claim. Right, so it's a huge item. So that's why they're doing these things. They also go, well, it's not my responsibility to pay for, an RA claim, to pay for a Hep C claim. It's not my job. My job is to make widgets, not pay for this stuff. I'm already paying employer health tax. Why am I paying for this? So what they do is they put these plans in place thinking that they're going to spin the cost off to someone else. And in Ontario, that's the Trillium plan. That's dangerous logic, because when we discuss this item with a client, and we do, because if we don't, someone else is going to come in and steal my client from me. We talk to them about it and say, if you have an employee who hits that maximum and they have to go to Trillium, it's going to be on a good time, an 8-week application. We don't know if that drug is actually going to be approved. We don't know if they're on the innovator biologic, if they have to go to a subsequent entry biologic, what the health outcomes of that are going to be. And I still can't guarantee that that drug is going to actually be paid for under the ODB. So do you want that person coming into your office and say, I've got a $40,000 a year drug and no one's paying? It's to the point now when we do have these discussions and a client wants to move this way, I'm asking them to actually give me clear direction that this is what they want and they fully understand what they're doing. Because I think one of these days it's going to come back and bite an advisor in the butt because they didn't fully communicate on what the risks of the plan were going to be. The scary part is that there's a lot of advisors out there who are actually recommending this as a plan design cost containment feature. I don't like it. I think it's distasteful, but it's happening, and the trend is growing, and it's growing in the small case market. Again, where most of the employers are. A little more creativity, and John touched on that, is the formulary plan design. So it's pretty much standard now. I think Sun Life is out reporting that 90% of their plans are on a generic, mandatory generic with an appeal process. So there really is, if there's a generic equivalent, the plan will pay to the generic cost. If there's a medical reason why the person can't have the generic, they can submit an appeal based on a medical information. And if the appeal is approved, they'll get the brand drug reimbursed at the brand cost. Some plans will put in a multi-tier formula where there'll be a preferred list of DINs on the first level, reimbursed at 80% per se, and then there's going to be a second list of drugs at the second level, reimbursed at something less than the first level. Another interesting one that's picking up more steam these days is mail order pharmacy. One of the providers prefer to call it active pharmacy. Mail order pharmacy has been around for almost as long as I've been in the business. As a matter of fact, everything I've talked about so far has been around for as long as I've been in the business. We just never made use of them. What we're doing now is we're shining them up, putting a new bow on it, and putting it out with a new name, and they're getting implemented. A little more creativity, and this has been around for a little bit of time too, is the prior authorization. And you in the patient support world clearly, I think, know what the prior auth is. The goal was to have the right drug at the right time for the right person. Now it's from the right source. And this is where the specialty pharmacies come into play. Some of the insurance companies have introduced contractual changes to slow down the entry of DINs onto the formulary. Most formularies today are still open formularies. If it is given approval by Health Canada, it's on the formulary. So what they've done, and all the big three have done it now, there was a company that went out on the bleeding edge and got beat up big time on it 2 years ago, and the other two big three this fall just announced they're going to do the very same thing. And what it does is really is that if a new drug comes out, it's typically, again, a specialty drug, it doesn't automatically come on the formulary. They're going to put it through an economic review. They're going to do something before they allow it to come in. Probably one of those things that are going to come out of it is a private listing agreement. The PLAs are in place now. Some of them initially started by the pharmaceutical companies to the insurance companies, but the insurance companies are getting much more active in negotiating these on behalf of their clients. And the clients like it. If someone's not in the PLA game, from an insurance standpoint, they're not in the game. And again, the specialty pharmacy side. And it's interesting, some of the things I've been finding out of the specialty pharmacy side, not all the healthcare practitioners like the specialty pharmacy because they're telling that practitioner's patients something that they don't know about or that they're not happy with. So it's, the specialty pharmacy world was to have the drug being eligible at a negotiated price, accessible at a convenient spot, having someone who knows what they're doing, providing the services. So here's the scary part, the sustainability dilemma. And Henry Ford said in sustainability, if you think you can do it or you think you can't do it, you're right. So if you think a private plan is sustainable, if you think a private plan is not sustainable, you're right. But this is the scary part that's coming up now, is the specialty drug spend. So in 2008, drugs over $10,000 represented 18% of the spend, and that held flat until 2011. It jumped to 21%, then to 23%, then to 25%, then to 28%, then 31%. And by 2020, we think that 50% of the drug spend on a private plan is going to be on specialty drugs, 50% on acute care medications and maintenance meds. The sky is going to fall one day, I think. Okay, I clearly don't think it's sustainable at the pace it may. Before I get out of the game, we may still be talking about this. We were talking about this when I got into the business. So we have to bend the curve. If we want the plans to remain in place for the employees when they need it on the catastrophic costs, we have to bend the curve somewhere. And where are we going to bend the curve? We're going to bend the curve on the 50% that we can control. So I know about the Serenity Prayer, not because I went to 12 or 11 steps, but it's know what you can change and what you can't change, and have the courage to change what you can. We can change the 50% of the maintenance medications. That's where we should be targeting. And John touched on it: diabetes, high blood pressure, hypertension, depression, cholesterol. And I had the good fortune to make a presentation with a diabetes health nurse a couple of years ago, and I didn't know about depression, mental health being part of the diabetics world. You know, and then I went back and talked to one of my own colleagues who's been a type 1 diabetic her whole life, and it was kind of like, you dumbass, Noelle, of course it is. You know, I've been injecting myself for 43 years, and I'm running out of places to do it. They just took away my long syringes. What am I going to do? You know, so when we look at this, we know this is the bucket of maintenance medications and maintenance health that we can work on. So we need to go from paying after the fact, when the disease state has hit, to bending the curve and stopping the event even taking place. Okay? Like it's a no-brainer. Why we don't do it, I don't know. You know, why do I have 2 cookies instead of 1 or 0? It's to make my wife happy so that I can show her that I appreciate her baking. That's my theory. And I went from 145 pounds when we got married to, I peaked somewhere else. So we need to be bending the curve. Will we ever flip it all the way around? I don't think so, but we have to start moving that way. And how are we going to do it? We have to rethink the coverage. If we want the plans to remain sustainable and be able to be in a place to afford the catastrophic costs of a high-cost claim, we need to start working on the non-catastrophic costs, what I call the budgetable non-insurance costs, and not let them become out of control. We need to shift the curve. We need to do more. Help employees avoid the need. Corporate health. I don't like the word wellness because we have let wellness in the employer world become something totally bizarre, to the point where I know a municipal employer in southwestern Ontario who had a wellness fair and brought 2 fortune tellers. You know, I've always wondered, do the fortune tellers know who's coming? So how do we do this? Well, I think we have to have a carrot and a stick. You know, there's a big, some chatter on right now, if you're a non-smoker, do you get more vacation days? You know, there was a company, I think it was in Japan, did that. So now it's picking up again in Canada. And then there's the stick. I know in the US, our US partners, if you have a maintenance disease state, you're identified. You then go to a health coaching. If you don't participate in a health coaching, you now pay more in your premium. Okay, so you're given the opportunity to help you get better, and if you refuse that, if you exercise your right to be stupid, you're going to pay for it. Right? We don't do that in Canada. We're fearful of that, so we spend most of our time on the carrot side. I think, and it's a huge debate between one of my colleagues and I, is which is it, the carrot or the stick first? I'm the parent that said no, and they always got yes from their mom. So if we really want the employee benefit plan on the drug side to be there when the employee needs it on the catastrophic cost, we have to bend the curve, start managing the things we can so that the plans can afford to still cover those specialty drugs that are catastrophic, and they are life-changing when people have access to them. That's the key thing. And most employers don't want to be in a position to not provide this coverage to employees. John does not want someone coming to his desk and saying, John, this is not covered. You know, if I don't get this, I go from 6 months of an expected lifetime to 2 months. You know, that's a conversation no one wants to have. So we have to bend the curve. We have to start working on the 180 so that the plan stays sustainable and the high-cost specialty drug, life-changing drugs are still available to employees. Thank you.
So, hello everyone, and thank you to Louise and your team for asking me here today. I'm really pleased to be speaking with you. One of the benefits of going last is I now know what they've said, so I can skip over those portions of my chat with you today. So as introduced, I am Joan Weir, and I am with the Canadian Life and Health Insurance Association. And what I plan to spend more of my time on, I have some fresh statistics for you, and some of them are a little surprising, so I want to go over a bit of that. I'm going to touch a little bit upon private drug plans, but really you've got a lot of information already, so I will go quickly through that. But where I'm going to focus is really on government policy, initiatives, and pricing. We have 3 organizations that all have a part to play with respect to drug pricing in Canada, and frameworks are in flux right now. So I'll give you some of that information. Hopefully, when we get through framework reviews and policy and decision making, we'll have a much better end-to-end system than we have today. So I will be talking about the Patent Medicines Pricing Review Board, the PCPA, as well as CADA. And then I'll just close with some actually fresh off the wire information from yesterday on pricing. And then I will close with a few questions for you. So our organization, I know that you're all very fully aware of us. We represent life and health insurers in Canada. But really what I wanted to let you know, not just insurers, we represent third-party administrators. That was a change we made a while ago, as well as pharmacy benefit managers. So we actually have a lot of the industry that works together on policy and initiatives. And another key point is we've gone a long way towards transparency over the past 5 years or so, and all of our information, our guidelines that our members abide by, are published at our website and are there for you to go and look up information as well. So, we have a big statistics department, as you can imagine, and throughout the year we collect data on all kinds of things from our member insurance companies and administrators. And we recently published our 2017 fact book, which is based on 2016 data. And some key information is extended health. 25 million Canadians now have private health insurance plans. And that's up from 24 plus last year, or 2015 I should say. And it may be surprising for you to understand that. Extended health in our world means drug, dental, and paramedical. But one of the key figures I wanted to point out to you is that 80% that's at the bottom of the slide with the people. And that's that 80% of working Canadians and their families have protection, are protected by private health insurance plans. And that's up from 67% 10 years ago. Now that may be really counterintuitive and hopefully surprising to you, because we do hear a lot about, part-time work, contract work, the gig economy, no benefit plans. It doesn't appear to be that way. The statistics don't bear that out. So that's a surprising one. And then I also put up there the circle, because you may think that if there is more coverage for people, maybe they're purchasing their own coverage more often through individual plans. And that, again, isn't really borne out by the statistics. So 10% of premium is individual benefit plans and 90% is group. And that's actually pretty stable over the last decade as well. Not much change there. So in 2016, we reached a new high. 32.5 billion in health benefits were paid out by private health insurers. And you can see that 75% of it is that big pot of drug, dental, and paramedical. But if you look at the division that's across there, you can see that 11 billion was for drugs, and it does not go down, it keeps going up. I think it was 10.6 billion last year. Interestingly enough, following directly behind that is dental. I don't think we as insurers give a lot of thought to dental pricing and dental utilization, but it's almost reaching $8 billion, so it's not far behind drug. And then you can see paramedical and vision is 3 billion, pretty steady, some increases there, and then it goes down beyond that. So we've heard a lot about costs rising and the requirements, the information around that. We know that the pipeline, so I don't think the pipeline's been talked about, at least in this panel, is full of cancer drugs and orphan drugs, very high cost, very innovative drugs. I mean, they're going to hopefully save a lot of people or make people's lives better, but they are very expensive. And how are we going to accommodate them into private drug plans? I think it was mentioned, some stats that I've got here, but I will also say one that I don't think was mentioned is that the top 1% of users are now the 28% of total costs. But if you just increase that a bit to the 5% of users, it's 50% of total costs. And of course, expenses going up, that's having a big impact on the Canadian Drug Insurance Pooling Corporation. It's growing over 25% a year. It is a separate organization from my organization, so I know just enough to be a little bit dangerous in this area, but it's undergoing a little bit of a transformation as well, because the costs, the growing costs, are just unsustainable from a pooling perspective as well. So this is the first year I understand that we have enough data to actually look at that issue of transferring plans from one insurer to another when there's a high cost or high cost claimants. We hear anecdotally that that's not happening, that insurers aren't bidding on programs with high cost claimants, but now we have enough data that we can actually take a look and see if that's true or not. So expect more from CDIPSI on that. And employers, we know, are demanding change. We know that employers have a much different focus than public drug plans, and that focus is on making sure their employees are satisfied, healthy, happy, at work, productive. So we've already heard about that from our employer colleagues. So this is where I'll spend a little bit of time. The Patent and Medicines Pricing Review Board had an initial review of their framework in 2016, and I'm sure that many of you actually probably put submissions in for that. Some of the key things that they're looking at are a value for money metric. It doesn't exist today in today's framework, and we know that around the world, similar type of organizations are incorporating a value for money framework in metric, and we feel that that should be included, and there's many of them that can be reviewed. Comparator countries, that's been the same list of 7 countries for decades and has had a great influence, we think, on high prices in Canada. And so definitely that needs to be reviewed. We actually suggested they get rid of that. Doesn't look like they're going to do that, though. And we suggested also looking at pricing reviews with new indications. So today, PMPRB looks at a drug once, and then that's it. So there should be other times when a drug is re-looked at, when the pricing is re-looked at with new indications or when comparable drugs enter the marketplace. So they actually issued a second review this year. It's closed as well. And some of the questions they asked were about an economic metric. They suggested GDP, and maybe that makes some sense, particularly from a public plan perspective. From a private plan perspective, though, we suggested they take a look at something that makes more sense from the ability for an individual to pay for drugs. So we suggested potentially median salary or something related to employment. And the list of new comparator countries is more than 7 and is actually looking pretty good in terms of incorporating some lower cost countries. We'll see what they finalize with that. They also suggested they'd like to see transparency, and I know likely you've talked about that, and that was a theme. Transparency on third-party rebates. Be transparency to PMPRB. It would not be outside that organization, we understand. But it seems to CLHIA that it's very hard to make decisions on pricing when the whole system is not transparent. So we don't know what we pay for drugs in Canada. We don't know what we pay for, or other organizations in other countries pay for drugs. So it's very difficult to create a pricing framework in that sort of environment. I just will mention a little bit Soliris. So Soliris is a very high-priced drug in Canada. You will know that, you may know that the PMPRB charged, if you want to call it that, them with excessive pricing in the Canadian marketplace. And there was a hearing held. CLHIA, for the very first time, was granted intervener status on behalf of private payers for Soliris as well. And the decision recently came out. We were granted the status. We asked that if there was a monetary refund, that it be to both public payers as well as private payers. However, when the decision came out, it was for public payers only, not for private players. And I must say, we as an organization are pretty disappointed by that and hope to see some change in that direction in future as well. So CADA, they've had a few changes themselves. They had a biosimilar review process this year, and they're looking at really streamlining the biosimilar review to a modified approach and making it shorter and bringing those drugs to market faster. And so we are supportive of that and would like to see that put in place. At the CADA Fall 2017 Drug Portfolio Review, I was surprised, and I know Louise, you were there as well, and probably many of you were, to hear that they stated more than 50% of drugs start CADA review prior to having Health Canada notice of compliance. So that was a surprise. And it goes to another one of your themes, which is really we're starting to see the effect of streamlining the process from start to finish. Government bodies are starting to work more collaboratively and side by side at the same time, not end to end. So we hope to see that have an impact on drugs to market and time for drugs to market soon. I'll just mention one other thing for non-drug. We as an industry are going to shortly be publishing best practices on CPAP therapy and obstructive sleep apnea. It's a really big cost driver for insurers. It's a very expensive treatment, and ongoing, it's expensive as well. And actually, we're going to adopt CADA's recommendations in this area. They did some expert review, probably it was last year they did it, but they published it this year and came out with recommendations that we're going to adopt as an industry. So I just thought, you'll see that soon. PCPA drug negotiations, I don't have much to offer on this front, but wanted to just say again that as with our 2013 policy paper, we continue to advocate for PCPA to negotiate drug pricing on behalf of all Canadians, not just public plans, not public and private, but all Canadians. And we think if that could take place, that would be one step on potentially the path to national pharmacare that may not be totally a public national pharmacare, but a public-private partnership. But, as I said, we're not there. So, just before I get to my last slide there, I wanted to get you some information about something that was published by the Montreal Economic Institute yesterday on drug pricing. And their position paper that you will find at their website is that actually drug pricing at the way we have it now stimulates and benefits Canadians, so higher prices do. And some of their points were reducing the maximum prices of drugs would make them less accessible. Canada is in the enviable position of having many drugs introduced much earlier than in other countries. For instance, New Zealand can be 10 years behind Canada for the introduction of new drugs. And in 2015, Canada was the 4th in comparable countries with respect to the proportion of new drugs brought to market. Delays in launching new drugs, Canada was only second to Japan so quickly, with average launch time of 90 days after approval. So all this good stuff, actually, that's the other side of the question, right? High prices deliver lots of drugs and to market and quickly, all despite the fact that our population is quite small. So I'll just end. We don't probably have a lot of time for questions, but my two questions for you would be, how much is too much to pay for a public or private payer to pay for a drug? And I'm interested to hear about your perspectives on medical cannabis and what it fits into whether it fits into the mix of what you're looking at for your patient populations. So I'll end it with that, and my contact information is there if you want to follow up with me after. Thank you.
All right, thank you to our panelists for some wonderful presentations. I don't think you were here yesterday, so I'll introduce, we have some patient respondents, and if you want to maybe begin by introducing yourselves, who have been commenting and asking questions after each panel as a way to start the Q&A process. So I'll hand it over to them.
Sure. I'm Martine Elias, and I'm the Director for Advocacy and Access and Community Relations for Myeloma Canada. And myeloma is a rare cancer of the bone marrow. So thank you very much for a presentation. I've been around in working in this industry in various types of position for many years, and I too also remember back in the late 90s where private plans we're introducing a lot of different cuts and sort of ways to manage their costs. And then the economy changed, and that kind of went on ice for a number of years, and now we're back to looking at drug price and how employers can manage them. I guess my question is, or my comment is, yesterday, I don't know if you were here or not, maybe some of you were, but the discussion really focused on value of drugs for patient. And what I hear today from the private payer side, and this, not just today, but at other conferences as well, is the focus is on cost containment, where else we've moved from managing cost at sort of the private payer level and looking more at what is the value of drugs for patients, the individual, the population, and the healthcare system as a whole. And I don't see that happening in the private payer area, where we focus more on the value that drugs bring to the employees and the employers as well. So I'm just wondering if that's something that you have in your radar screen that you'll be looking to sort of change and talk more about value. My other comment is around the Generation Y. As a mother of 3 kids that are entering the Generation Y, their focus is very different than the baby boomers, and wondering how changes to private healthcare plan will affect the Generation Y, because their needs are very, very different than the baby boomers or even the Generation X. And they're not looking at, you know, healthcare plan, because they depend a lot on, they're still on my direct plan, to be honest. So at some point in time, like, you know, they're going to be hitting a bubble, and how are those going to be managed? Because I think employers, as they move forward, you know, having a drug plan is it's cost of business in Canada, and if it was something that was not necessary, they would have abandoned them a while ago. So it's still going to continue, I'm sure, into the future from a competitive reasons. So a few questions here, but I'm going to pass it over to Linda to see if...
Wow, started with the big shotgun there, right? Okay, from an employer's perspective, value. Value is the whole reason we actually got into the provision of group benefits in the first place. As I'd indicated as part of my presentation, the expectation originally was to introduce these programs as a differentiator. We wanted to provide people with a different type of compensation, something that wasn't strictly cash. And essentially, it was intended to provide people with a perception of a safety net. We're going to help to take care of you. It's not just a matter of we give you money, you go away. There is an acknowledgement at some point in time that, especially over longer service employees, all right, you're going to become part of our corporate DNA, our culture, all right? My organization has been around for almost 100 years. And we have some employees who have worked their entire lives, and we've celebrated anniversaries of people who have worked within my company for 45, almost 50 years, all right? And that's been pretty impressive, because again, they are part of our corporate DNA. It's important for us to be able to ensure that the values that they held are continued on with the subsequent generations. Now, there's a challenge, of course, and that's the cost. These things are always going up, and they're getting more and more expensive. So the point that I've been making, and that everybody else in the panel has been trying to stress as well, it's a balancing act, trying to figure out what is the best way of being able to provide value at the lowest possible cost. Consumer-like behavior is certainly one way of doing it, all right? One of the things that we have to understand and appreciate is the fact that, especially now in the 21st century, we have multiple channels of communication. People have evolved, literally, within the last couple of decades. They've evolved. I'm not just talking about the demographics, but the way we absorb information, receive information, and utilize information has changed significantly. Many of us used to get our information from, newspapers, the Globe and Mail. Now we could be sitting on the train and we're looking at stuff like this all of the time. So we need to be thinking about ways that we can communicate information to the end user. That's how we're going to provide them with value, by educating them, by giving them more information. But it has to be the right kind of information. Coming back to a point that I'd made earlier about flex plans, too many options, too much information, and people essentially zone out. They don't make choices. That is actually an academically studied piece of human nature, all right? So what we need to be able to do is we need to disseminate it down to its simplest and clearest essence and provide that information to people in the best of possible ways, ideally through multiple channels of media, to get them to at least pay attention on one, maybe even two of those channels. It's not always going to be successful, and it's an uphill battle because there's so many things that compete for people's attention. All right? Benefit programs, the value of drug programs, how much these things cost. We have to think of different ways of communicating that out to them. And here is the biggest challenge. That's not an employer's job. That's not what we're in it to do. We need the assistance of others, whether it be the consultants, whether it be the regulatory bodies, or whether it be advocates and clinicians. We need others to help to drive this type of message through so that people can understand what it is that they are actually getting. There is value here, but there's also a lot of waste. And if you want to sustain something, you need to be able to do away with a lot of this waste. And that's a message that all of us need to understand, all of us need to absorb, and all of us need to share with each other and with the people that we're working with in order to get them to appreciate what it is that they've got. With respect to the generations, now, that's a pretty interesting one. I've heard different perspectives with respect to the different focus of boomers versus Gen X versus millennials / Gen Y. And one of the interesting things that I think we fail to grasp is the fact that it's, again, an evolution. We've never had so many different generations in the workplace at the same time. Fundamentally, you've got to ask, why is that? Realistically, the answer is pretty simple, all right? The nature of work has changed, and people aren't dying as young. Plain and simple. If they're not dying as young, they're sticking around. Many are staying in the workplace, all right? That's why we're seeing so many generations in there. We're essentially bunching up. But all of this stuff about, you know, the different focus of boomers versus the different focus of Gen Y, well, guess what? In 15, 20, 30 years' time, those people on the Gen Y side are going to be thinking the same way as the boomers are today. It's an evolution. We're all going to get older. Our focuses, our priorities are all going to shift as life experiences are all brought in. Hey, I wish I could think like a 20-year-old, but I don't have the body of a 20-year-old anymore. I don't have the responsibilities of a 20-year-old anymore. I'm an whatever age I am right now, and this is what I got to deal with. Don't go there. All right? That's going to happen to the boomers. It's happened to the boomers. It's happening right now to Gen X. It's going to happen to the millennials. We all thought when we were young that we were invulnerable and able to do anything and get away with it. We don't necessarily think that now. They're going to grow up at some point, and they're not going to be thinking it either. That's our perspective.
I'll touch the value part maybe slightly differently. I don't think a lot of employers are looking at the health outcome of their drug spend for their employees. It's a great question. And you know, some of the pharma people that I've worked with over the years say, well, if you want an employer to continue to pay this drug, show me the economic reason why they would do it. And some of them have come to the table and provided me with information that, you know, if you didn't pay this person would be off on long-term disability sooner than they might otherwise be, and your costs would be going up. But that's on the specialty side. You know, I'll focus back on the 50% that we can control. If we didn't spend X number of billions of dollars on statins, would my employees still be at work? You know, what does the health come out of that spend? We don't go there yet. We're going to have to, and the focus has been on the specialty drug side. On the when will Gen Y, what will their benefits look like? And it's funny, John and I had a chat on something else earlier, but it's essentially the victor writes the rules, and when Gen Y is in control, Gen Y writes the rules. If you would go back and look at why things are in an employee benefit program, and I did this for a presentation last week, I looked at an employee benefit program from 2000, and it's identical to what it is today. Again, I've been doing this a long time, I went back to try to find a contract from the 70s, and it's pretty much the same. So who wrote those back in the 70s? Someone with a self-enlightened interest. You know, the CFO said, hey, I need this covered, put that in the plan. If it was through collective agreement bargaining, it got put in the plan. So that's what drives plan design. Some progressive employers will look at it and say, we have a disability problem here, we have a health problem here, let's design our plan to manage that in a better way. So to John's point too, when the Ys are 50 years old, will they still be designing plan design like a 50-year-old today? Probably.
And the only piece I'll add to that is really on the value. We do focus a lot on economic value, returning people to work, keeping them productive, all of that thing. But I think we need to add in that there is a societal value and there is a non-economic value that needs to be considered as well when you're looking at drugs to add to your drug plan.
I'm Linda Wilhelm. I'm with the Canadian Arthritis Patient Alliance, one of the patient groups that account for probably your biggest number in some of your spends for the biologics I'm talking about. I mean, I was at a conference probably 5 years ago, and the same kind of thing was forecasted, the growth of the expenditures and the pooling of insurance and the need to work with public payers. And how come it's taking so long for you guys to start working with the public payers? Public payers have been talking about this stuff for 20 years. I mean, as long as I've been around. You guys kind of started to mention some of this stuff 5 years ago. When I started a biologic in 2000, there was no criteria for my insurance company that I had to fail other drugs. I did, because I've had this disease for 30 years, and I ended up on a biologic because nothing else worked. But you guys didn't start implementing criteria until very recently. Medivie Blue Cross in Atlantic Canada, because they work with the New Brunswick Public Drug Program, did implement some criteria more than some of the other insurers. But honestly, I mean, it's just sometimes I wonder that you're already dealing with things that you've kind of made happen. And I think that, you know, we need to get together and start working public and private together and managing costs. Because when I look at the neighbors south of the border, I mean, we're actually pretty good here in this country. You guys are only having to cover drugs and you know, not cover benefits that aren't covered under our healthcare system. Down in the States, they've got to cover the whole shebang and throw in profit to add to that. So, you know, I think that, you know, the insurance companies here maybe don't have it as bad as other places.
So maybe I'll start this one off and just talk about working with public payers. I would say 5 years ago they weren't ready. They weren't ready to start to work with private payers. I think they're becoming more ready now. They're seeing the advantage of it. You know, many of them, like I'll just say PCPA. So PCPA has been a work in progress. They, you know, basically incorporated Quebec and the feds just recently. They really just established a national office just recently. They themselves have their challenges with respect to the number of drugs that they can review with pricing. So they're simply not at this point ready to consider how to incorporate private payers. I think the other organizations, from my perspective, there's been an unprecedented amount of collaboration with public drug plans and private drug plans. And a good example of that is, you know, the OHIP Plus program that's coming in. We've probably worked with them since 2 days after the announcement was made. They were knocking at our door. And, you know, we'll hopefully see the benefits of that collaboration by having a well-implemented plan, let's hope. But that's what I would say about collaboration at this point in 2017.
I guess we'll just keep going this order. So the clients I work with, every year they get a renewal. You know, so the life, LTD, short-term disability, health and dental rates all go up. We get a bottom line change. Most plans are experience rated on the health and dental to some extent. So you used $100,000 last year, it's going to be $100,000 next year plus inflation, that's your cost. And the number of times that I put a renewal through and there are no plan design changes following. So I look at it and see your cost just went up 20% for the program and you're accepting it. So you just told me that the plan is sustainable for another year. Now, John may have the number for his own firm, but employee benefits represent around 7 to 10% of total compensation. So the reason there hasn't been greater push on the private, or from private to public, is because the costs haven't hit the point where they're screaming loud enough to get public engaged more. It's a small part of the big world of an employer. It's a growing part, but the friction hasn't been there enough yet for them to really be screaming. And then I'm talking more so the small employers. Again, they're making widgets. If I can put that cost increase in the benefit plan through that widget, okay, let's move on, because I don't want to upset the employee experience on the plan design. And I think that's what's kept the two apart.
Don't hate me. I want to say one thing very, very clearly here, all right? And I think it's really, really important for everybody to understand. Diversity in this space is a given. When I say diversity, I'm talking about people who have a different point of view, a different perspective, a different focus, a different agenda when they come to the table and have these discussions. All right? You could be a patient, you could be a clinician, you could be a pharma provider, you could be a consultant, you could be a legislative body, you could be an employer. All right? Everybody comes to the table and you've got a different focus. You've got a different point of view. You have a different agenda when you're sitting down and you're looking at the people across the table from you. As an employer, I want you to understand, in the private sector, we want to be good corporate citizens. In the private sector, we want to be a part of the communities in which our employees are working. In the private sector, we're about profit. We're about money, making that profit. Because without making that profit, there is no way that our business is sustained. All right? If that business is not sustained, none of the stuff we're talking about happens either. This is a very, very important perspective. And I'm not saying it to rub it in anybody's faces. I'm saying it because it's something that everybody tries to avoid. Oh, you're talking about money. That's such an ugly type of a thing. By the way, that's a North American bias. In other parts of the world, that's not so much. All right? That's a North American bias, where it's supposedly dirty to talk about money. All right? The reality is none of this happens if we don't pay the bills. All right? And I'm not just talking about we as in, the corporations. All right? We as individuals, we pay our taxes. We're contributing to all of this as well. There are different types of programs that are out there. But you have to understand that all of this still comes down to somebody's got to collect the money from somewhere in order to make any of this stuff work. Respect and pay some attention to how that can be sustained. If it isn't, eventually you're going to do yourselves out of a job. That's a reality. That's it. Don't hate me, please.
Unfortunately, we we have 3 minutes left. We did start this panel 10 minutes late. I know Louise had a question, and our speakers will stay during break as well if you have questions for them. So we'll encourage you to go see them individually.
Thank you very much. I really enjoyed this panel. I don't know about anybody else, but I really enjoyed this panel, so thank you. John, you, in passing, just kind of briefly, but it stuck with me, made the comment about, well, we don't want to pick, I'm paraphrasing, we don't want to pick on specialty drug groups because that would be discriminatory. You sort of, something like that. Noelle, you made the comment about, let's not, 50% of the specialty side we can't do much about, let's work on the other side. And that all resonates for me. And yet, what I see at the insurance industry side is that, in fact, that's exactly where the emphasis seems to be, is on trying to, deal with the costs of specialty drugs. And don't take me wrong, I understand affordability. I think all patients do. We understand sustainability. Believe it or not, unlike some governments I could name. We actually even understand private sector and the profit motive, and we don't actually think it's so dirty, okay? We think it's just fine. So, so how do we, I think a lot of what we talked about yesterday was just what you folks have talked about. We all are going to have to get together and figure out this problem. We're not going to figure it out alone, neither are you. But I haven't seen a lot of patient/employee engagement in solving the problem. Like the insurers are solving it the best way they know how, you guys are solving it the best way you know how, but I haven't seen very much. I'd love to see, for instance, a meeting where we bring all the stakeholders together, including representatives for your employees, and including patient advocates, who thank you for not thinking we're dirty words either, and really see if we can't recognize each other's diverse perspectives and see if we can't come up with some solutions that aren't, as you suggested, discriminatory against one group or another, that does recognize where we can make differences and can't. I mean, when so many people, for instance, in this country are getting cancer, and a lot of them are getting to be younger, unfortunately, this is a thing we've all got to, we just can't hide in the sand about this. So is there any thinking from any of you about the possibility of some kind of another summit that really kind of drills down into this, where all of us can talk about it and share some solutions?
From an employer perspective, I think it comes down to our actual experience and utilization, all right? An employer has to be of a size large enough that a specific demographic section of any one of the advocacy groups or specialty areas actually has a percentage of employees, where we have a percentage of employees that are impacted by that. That gets our attention, all right? Because we have a balancing act, again, that we have to do. And one of the things that nobody's mentioned here is one word, and that's called privacy, all right? We cannot be tackling this on an individual basis. Everybody gets up in arms about privacy of information and the possibility that, information can be used incorrectly. So that means that it has to be brought to our attention collectively as a group. So to the point that was just made with respect to increasing incidence of cancer, if there is a way for us to gain the focus of acknowledging the fact that, yeah, this is the percentage change over time of cancer incidence inside of our workforce, that gets our attention. And we start to think, okay, what can we do to address this? Because from our perspective, coming back to the business perspective, if somebody has that issue, somebody has that problem, it makes sense for us to try and proactively find a way to minimize the impact to the business. I'm going to keep coming back to that, to minimize the impact to the business. Not necessarily spending more money, but try and minimize the impact to the business. Keep them productive for as long as possible. Find a way to bring them back to a healthy place as quickly as possible. Those are things that we need to be able to do, but we cannot do it on an individual basis. And I'll be blunt, most of the time that things like this come to our attention as employers, it's on an individual basis. All right, we do not have this type of information automatically being fed to us and provided to us. And again, it's not our core business to focus on that. So if there's a group out there that has that interest, all right, then there needs to be work done to try and find a way to gather that information and present it to us so that it gets our attention. Then we can focus on it and try and work together, collaborate collectively. But an individual one-on-one type of a way, it's not going to work. That's going to be a bit of an uphill battle for everybody.
I'm going to build on the privacy side. The reason we can't do really good, aggressive, and I'm going to use a soft, aggressive health coaching on where I like to focus on the maintenance spend is the fear of privacy. How can I identify that person and get them the coaching without them self-declaring they want coaching? We really have to get over that hurdle to be able to do it. They do it in the US. You know, they've overcome that somehow. So if we can find a way to do that, we're going to be able to much more focused health coaching on the manageable disease states to be in a position to afford the specialty drugs. And I don't know when that's going to happen.
Yeah. And I would agree that there needs to be more patient engagement in private plans. You know, insurance is a long-standing insurers are long-standing organizations, and they're very conservative, and it takes a long time to kind of shift the boat in another direction. But I do know, to the patient involvement and privacy piece of it, that insurers and some medical directors of employers are feeling more comfortable with insurers. We know who's taking what drugs, probably for what reason, doing targeted patient communication to people on type 2 diabetes drugs. So that's happening more and more often now. You will see that, but again, that patient engagement, that response back is very difficult to get.
Individually. Thank you, and thank you very much to our panelists for some great presentations. Thank you.